actually very simple. If I was to finish it in one line, I could have done it. A safe target, like I teach my MBBS students, I also guide them that suppose you're caught in a fix and you're attempting a theory paper and you don't know something and causes of ABCD are asked, just remember the 3 I's and 2 T's. Infection, immunological, ischemia, humor and trauma. They can affect any organ anywhere. So if you forget the causes, just enumerate these in your life or anywhere. At least you get something out. And you should actually be looking for it. Similarly, as far as the targets of hypertension are concerned, we all know the benefits of lowering BP. It reduces the incidence of stroke by 25 to 40%, the incidence of myocardial infarction by 20 to 25%, and that of heart failure by 50%. Now take the case of a 50-year-old woman who is a diabetic, has dyslipidemia, has a blood pressure of 158 by 94, which is confirmed on several hospital visits. Other than obesity, the examination is normal. The labs show normal renal function, well-controlled lipids on atorvastatin, and well-controlled diabetes on metformin. The urinary microalbumin is mildly elevated. Now, why I presented this scenario? Because it has all the ingredients which a physician needs to be aware of. The age of the individual, the race of the individual, the comorbidities, whether it's diabetic, there is involvement of the kidneys or not. So these are the parameters which should be in your mind before you set the goal which this patient should have. So the question would be, what would be the ideal goal of blood pressure in this patient? 150/90, 130/80, 140/90, 140/80, 140/89. This talk would like to emphasize at the end that what would be the optimal goal in this kind of patient. Because we are surrounded by so many guidelines. These guidelines are aimed to guide us. They are not the final word. The final word rests with the physician who is examining the patient and has an absolute knowledge about there are certain patients who do not tolerate certain blood pressures. It's not that we are going to emphasize and make sure that this patient has to have low blood pressure when the patient is developing other symptoms which the patient cannot tolerate. GMC has been the gold standard. This was a panel which was appointed by National Heart, Lung and Blood Institute, and the first guidelines were published in 1977. Subsequently, the updates came at every 3 to 6 year intervals, and the last edition was GNC 7, which was published in 2003. GNC 7 classified BP into normal pre-hypertension, stage 1 and stage 2. A normal pressure of less than 120 systolic and less than 80 diastolic. 120 to 139 was termed as pre-hypertension, and stage 1 and stage 2 were described between 140 to 159 and more than 160. In comes GNC 8. It was commissioned in 2008. 400 panel members were appointed. They developed focused critical questions which were relevant to practice, and a systemic search of pertinent literature was conducted. The focus was limited to randomized controlled trials which were published between 1966 to 2009. Patients over the age of 18 with hypertension were included. The studies needed to have a sample size of at least 100 patients. The results must have included hard outcomes. As far as the subsequent studies between 2009 and 2013 were concerned, they actually needed more than 2,000 participants. They have to be multi-centered, and they should meet other inclusion and exclusion criteria. So in 2013, the NHLBI decides that it will no longer publish the clinical guidelines, and they propose to work collaboratively with other organizations. The appointed panel members for GNC 8 decided to publish their findings independently, which were published in JAMA in December 2013, and they did not receive endorsement from other organizations. So what were the 3 important questions which, regarding hypertension management, were addressed? Does initiating antihypertensive pharmacological therapy at specific BP thresholds improve health outcomes? The second, which is the focus of my talk, and I will limit myself to it, does treatment with antihypertensive pharmacological therapy to a specified goal lead to improvements in health outcomes? Because that is what we are ultimately concerned about. And do various antihypertensive drugs or the drug classes differ in comparative benefits and harm on specific health outcomes? So what were the recommendations? First of all, in individuals who are elderly. Now the definition of elderly also varies. Some included more than 60, the others included more than 80. As far as JNC 8 was concerned, they said that individuals more than 60 years of age start medication at a blood pressure of 150 by 90 and treat to a goal of less than 150 by 90. In patients more than 60 years of age, the treatment does not need to be adjusted if the achieved blood pressure is lower than the goal and well tolerated. Hypertension in the elderly is of concern to us. We also have got an aging population, and the number of patients in the elderly age group are far more than they were earlier. The prevalence of hypertension is high. So there are several issues which make the management of hypertension unique. They often present with isolated systolic hypertension. They're more likely to present with comorbidities. There are many clinical trials in hypertension which have excluded these patients, particularly those who are more than 80 years of age. And the elderly are more susceptible to certain adverse effects, for example, orthostatic hypotension. So this trial, HIVEC, which was published in 2008, was in fact acclaimed as one of the best trials in the last 10 years. Now this was a randomized double-blind trial which included close to 4,000 patients. They included patients who were 80 or older with a systolic blood pressure of more than 160. The patients were randomized into two groups to receive a diuretic indapamide with or without perindopril or a placebo. The target blood pressure was 150 by 80, and the primary outcome was a fatal or non-fatal stroke. What did the results reveal? The mean blood pressure at the end of the trial in the indapamide plus minus perindopril group was 143 by 78, whereas in the placebo arm it was 158 by 84. 48% of the indapamide patients achieved their goal of blood pressure versus only 19% of placebo patients. The outcomes showed that there was a 30% reduction in stroke, a 64% reduction in heart failure, and a 21% reduction in all-cause mortality. So HIVEC demonstrated that treatment of hypertension to a goal which was less than 150 by 80 in patients more than 80 years old was safe and effective. What about a lower BP goal, and what about patients aged between 60 to 80? These issues still need to be addressed. In the second group of patients, those who are younger than 60 years of age, the JNC recommends that you start medication at a blood pressure threshold of 140 by 90 and treat to a goal of less than 140 by 90. In all adult patients, now this is the third group, diabetic or chronic kidney disease, thresholds again to start medication is 140 by 90 and the goal is less than 140 by 90. The ACCORD trial, which had three arms, the arm for the glycemic control, the arm for the lipid control, and the arm for the blood pressure control, was a randomized double-blind trial, and it included all patients with diabetes who had a high cardiovascular risk. Now they were randomized for a target systolic BP control of either 120 or 140. The primary outcome was measured in terms of cardiovascular death and or stroke. The results included that the mean systolic BP was attained at 119 in one arm versus 133 in the other arm. They did not observe any significant difference in the primary outcome. The incidence of stroke was lower with the intensive treatment, but there was a significant increase So the results of ACCORD provide no conclusive evidence that an intensive BP control strategy reduces the rate of the composite of major cardiovascular events in such patients. So JNC also recommends that you have to initiate therapy according to recommendations. If the blood pressure is not at goal in 1 month, increase the dose or add a second agent from the recommended class. If the patient is still not at a goal, then you add a third drug from the recommended classes. Do not use ACE inhibitors and ARBs together. The drugs from the other classes may be used if additional BP lowering is needed or if there are any other contraindications. And if you are caught up, you're still not able to control it, it will be ideal to recommend the consultation of a hypertension specialist. Now this is another major trial, the SPRINT trial. I'm not going to focus on too many, I've just picked up 2 or 3 very important trials which do convey the message to us. Now this is the systolic blood pressure intervention trial, which was released in September. It's an NHLBI sponsored trial. They've taken more than 9,000 50-year-old plus Americans across 100 centers of the US. It's the largest study of its kind, and it was stopped 6 months early due to a significant difference. What they found was that the target systolic blood pressure of less than 120 reduces cardiovascular events, heart attack, congestive heart failure, and stroke by 1/3 as compared to a target systolic blood pressure of 140. The risk of death is reduced by 25%. The more intensive group, on an average, was receiving 3 drugs, whereas the less intensive group was using an average of 2 drugs. The final results of this study are yet to be published, so we might have some data in there. But on the whole, what we find in this trial is that the systolic blood pressure of 120 compared to 140 is likely to have much better outcomes. There are many other guidelines, the European Society of Hypertension, the American Heart Association, the ACC, the American Society of Hypertension. All these trials have recently come in, and I'll show a comparative of what their ideal goals have been. Now this is a comparison between JNC-A, DSH, AHA and ASH, that what is the threshold for drug treatment. So if you see, the major things are, one is the age of the individual, 60 or above, 60 or below, what is the threshold at which you start the treatment, and what is the treatment goal. Now if you were to compare the goals of blood pressure across these groups, the last group is the Canadian group, so one would find that at ages less than 60, almost everyone is uniform that the target is 140/90. Between the ages of 60 to 79, JNC-A would recommend a target goal of 150/90, whereas the others recommended 140/90. At ages of 80 plus, it's between 140 to 150 as far as the systolic pressure is concerned. Diabetes is always a major concern. We've always been taught that lower the better. So what the European Society recommends and the Canadian group recommends is a lower blood pressure of 140/85 and 130/80 respectively, whereas the other groups would recommend 140/90. Patients with chronic kidney disease, again, a target goal would be between 130 to 140 and the diastolic between 80 to 90. So if I was to summarize what the trials, what the recommendations, what the guidelines were to say, the systolic blood pressure goal for most would be less than 140. Patients who are at low moderate risk, patients with diabetes, patients with previous stroke, and in the elderly, the goal would be somewhere between 140 to 150. And patients who are fit elderly, age less than 80, my goal would be less than 140. The diastolic BP goal for most would be less than 90. As far as people with diabetes are concerned, it's mandatory to initiate drug treatment in patients whose systolic blood pressure is more than 160, and it's strongly recommended that we should start treatment when the systolic pressure is more than 140. The goals would be again 140 and 85. All hypertension treatment agents are recommended and can be used in patients with diabetes, but the choice of hypertension treatment must take into account the comorbidities. In patients who have a nephropathy, consider lowering the systolic blood pressure to less than 140. Consider a systolic blood pressure of less than 130 in patients with overt proteinuria. Monitor the changes in the eGFR, it was talked about in the previous lecture too. The RAS blockers may be more effective to reduce albuminuria than the other agents. A combination therapy is usually required to reach the BP controls, and a combination of two RAS blockers is not recommended. Aldosterone antagonists are also to be used with extreme caution in patients with CKD. We are Indians, and we have the Indian Hypertension Guidelines, the third edition, which came up in 2013. Professor Wander has been an eminent person in the publication of these guidelines, the compilation as well as the publication of these guidelines. So how do we differ from the Western guidelines? It was quoted that in view of our special geographical, ethnic and climatic conditions, dietary habits, literacy levels and socioeconomic variables, significant differences need to be addressed as far as our population is concerned. And the primary aim of these guidelines was to offer a balanced information to guide clinicians rather than rigid rules that would constrain their judgment. The core committee recognized that the responsible physician judgment remains paramount for individual patients. That's what I started off with. We also find that the term pre-hypertension, which was introduced in JNC 7, is more likely to cause anxiety, and they did not recommend the use of this term. They classified blood pressure in ages 18 and above into optimal, normal, and high normal at pressures of 120, 130, and between 130 and 139 respectively. Hypertension was classified into three stages, 1, 2, and 3. If the pressures were between 140 to 159, 160 to 179, and more than 180. The diastolic ranges were between 90 to 99, 100 to 109, and more than 110. In patients with isolated systolic hypertension, grade 1 was when it was between 140 to 59, and grade 2 was more than 160, with the diastolic pressure being less than 90. The target blood pressure, which the Indian Hypertension Guidelines have recommended, is that in young and middle-aged patients, a BP goal of less than 140 by 90, in diabetics, less than 140 by 80, in patients who have survived stroke, less than 130 by 85, and in the elderly patients, 140 to 145 systolic and less than 90 is diastolic. So how low can we go? The primary aim of my talk today was sensitize all ourselves to the issues which we need to address in the cross-section of patients that we come across, depending upon their age, depending upon their comorbidities, whether it's diabetes, whether it is chronic kidney disease. A goal, the accurate measurement of blood pressure, the instrument used in blood pressure, the number of times you take the blood pressure, the settings are all important. We should realize this, that measurement of blood pressure should not be a very casual affair. Differences of as low as 5 to 10 millimeters of mercury could make a vast difference to the lifestyle, the length of life of any individual. I'll stop here and thank you very much for your attention.